talk about breast cancers, and this is a surgery topic. A couple people had requested a talk about something in surgery last time, so we're going to go over this, and that will include our simulated patient case, a physical exam with differential diagnosis, going over our assessment and plan, and then we'll do a little bit of a pathology lesson of breast cancer at the end to kind of help you guys understand that process. So if you're looking to participate, then you can fill out the SOAP note and quiz as we go through the presentation. And then if you ever need to go back or have any questions about some of the content, then of course we're able to revisit any of the slides that might help you guys out with the quiz. And then if you have any questions at all, also please either feel free to put them in the chat or unmute yourself, and I can see what we can do there. All right. We're going to skip the annotation today just because we're running behind, but usually we have people from all over the place, and I'm really appreciative for your guys' time. So again, I really apologize for being late today. So we're going to start off our case. We have a 54-year-old female who is presenting for her annual physical and health screening, and she has no prior medical conditions that we know of. So what would be some screenings that we would recommend that she get as a 54-year-old female who hasn't been seen in 5 years? And this could be across like any system, any disease process that we would maybe want her to be evaluated for. Cole's saying a mammogram, that's a great idea. We usually start doing mammograms, usually either between age 40 or 50, depending on their individual risk. And they're recommended every 1 to 2 years, again, depending on what the patient's risk is. So as a 54-year-old, she's definitely in that window of where we want to be doing a mammogram for her. What other general health maintenance things that we would maybe want to consider screening her for? Maybe some conditions like diabetes, blood pressure, lipids like cholesterol, things like that, that we'd want to see how she's doing and what her baseline would be. These are the lists that I came up with. So for metabolic, to diagnose and screen for diabetes, we do a hemoglobin A1C. That's a measure of your average glucose control over the last 2 or 3 months. And so can kind of give you an indication of if you're chronically hyperglycemic. You can also do kind of a snapshot in time of what the glucose level would be with just a fasting glucose. I had mentioned a lipid panel that screens for cholesterol and triglycerides. So if they're elevated, then we would be concerned for potentially risk of cardiovascular disease. And then your basic metabolic panel would help us to evaluate her kidney function and electrolytes. For cardiovascular, we take blood pressure at every visit, generally regardless of age, but she is at an age where hypertension is prevalent, so we'd want to see what her blood pressure would be. Depending on her social history, then we would consider doing like an STI panel if she has high-risk sexual behavior. Things like HIV and hepatitis C virus could be other things to screen for. For cancer screenings, Cole had already mentioned doing a mammogram, which I said is every 1 to 2 years. Other cancer screenings that we would want her to get would be like a skin check. That'd be something that you can do just with your primary care doctor every year, where they look for any suspicious moles or lesions on the skin, be able to biopsy those and just kind of monitor for any changes. Colonoscopies start at age 50 and are recommended every 10 years unless there is some high risk findings. So because she is after 50, we would for sure want to get her in for a colonoscopy, and then a pap smear as well to screen for cervical cancer. So that can be done if you have low risk every 5 years. And then just general mental health screening. So depression and anxiety are just 2 questionnaires that we can do in office. They're just like surveys that patients take about how they are doing on kind of like a day-to-day basis, and then can be used to start a conversation about their mental health. We always like to also screen, especially women, for domestic violence and safety at home. And just to kind of see how their social situation is, and then also about drug and alcohol use. So that's just all kind of just good practice, primary care and preventative medicine, to see if there's anything that we can do to help this patient maximize their well-being. So to get back to our case, she has no complaints other than she did notice a new lump in her left breast. She said that this lump appeared about 2 months ago, and the lump is about the size of a pea. It is not painful for her, and she has not noticed any swollen lymph nodes. For her past medical history, she doesn't have really any previous diagnoses. Like we said, her only medication that she takes is a multivitamin. For her family history, she has an aunt with invasive ductal carcinoma of the breast that was diagnosed at age 68. And we'll go through kind of what that means. But invasive ductal carcinoma is a type of breast cancer. For her social history, she works as a waitress at a local restaurant, and she enjoys gardening in her free time. And then we also want to include a review of systems. So given that she has this new complaint with the lump in her breast and with a family history of breast cancer, there are some other symptoms that we would want to screen for to see if she's been experiencing. So that'd be things like fever, chills, and weight loss, any like swollen lymph nodes, shortness of breath, headaches, change in bowel habits or change in urinary habits. Those can all be signs of either advanced disease or metastasis to other organs. So it's a good thing, I think, that she's negative for all of these, meaning that there's no obvious signs of end organ dysfunction related to this new complaint of hers. And again, for the SOAP note, if you guys need to come back to this slide at all, then I'd be happy to do so. Okay, so moving on to her physical exam. This is great information for the objective portion of the note. Her blood pressure is 130/82. Her heart rate is 71. Her respiratory rate is 14. Her temperature is 36.9 degrees Celsius. Oxygen is 99%, and her BMI is 22. So of all these vitals, they're looking pretty good. She's just a little bit borderline high with her blood pressure. And this could be kind of due to various reasons. It could even just be that she had been kind of walking into the office and her and she was active recently, and so her blood pressure is elevated. So usually the first thing we do is recheck to make sure that that's a true number. But if that's actually what it is, or if it's higher, then we would consider starting her on some blood pressure medication. For her physical exam, she is kind of like just a normal appearing female who appears her stated age. Her head and neck exam is unremarkable. These are all just kind of like normal findings for this patient, no cardiac or pulmonary findings. And then where it gets a little bit more interesting is her breast exam. So she did mention that she noticed a new lump. So when we're doing our breast exam, on the left side, we find a 2 by 3 centimeter firm, fixed, and non-tender mass in the upper outer quadrant at the 1 o'clock position. So I have a picture that is on the next slide that I think does a good job of kind of explaining how we map out what the position of different masses in the breast are. And it's really important to document the location of the lump and the size as thoroughly as possible, so that when future people are doing exams and workup of the lump, then they would know where to be looking at. She also does not have any palpable axillary lymphadenopathy. So axillary referring to the like armpit area, and that's where especially breast cancer tends to be affect the lymph nodes the most of the time if it has metastasized to the nodes. So I think it's a reassuring finding that she doesn't have any palpable lymph nodes in her armpit area. And then her abdominal exam and her extremities are all looking normal as well. So really the main findings here is just in that left breast. The rest of it is pretty unremarkable. And so this was the breast exam that I was referring to. So sometimes people do actually include these images in the notes that they write, but you always start by saying how large the mass is. So in centimeters, if you're able to measure with either a ruler or based on feel and compare it to like an object even sometimes can be helpful. And then we also use the clock face method for describing where the lump is in the breast. So with it being at the 1 o'clock position on the left side, that's going to be in the upper outer quadrant. And we also like to include how far it is from the nipple because it could be closer or further away within that 1 o'clock position. And this will just continue to help make sure that it's well documented where the mass is. So that kind of gives you an idea of where this mass is located in her breast, so that if we needed to do like an ultrasound or a biopsy, then we'd know where to look. So does anybody have any questions right now about our patient, right, and her physical exam or her history? Otherwise, we'll just kind of keep moving along, and we can always go back if we need to.
I have a
So,
question.
oh yeah, does it, Tamahina, I'm sorry if I say that wrong. Did you have a question?
Yes, I did. I was wondering, does it matter that the nodule is
I'm not
facing a certain
hearing
position?
if you're unmuted
Oh,
or not. So if you have one,
sorry.
then just feel free to put it in the chat. But
Yeah,
actually,
okay.
sorry,
Sorry.
my volume was down, so I can hear you now.
Oh, it's fine. I was just wondering, does it matter that the nodule that she's describing is facing a certain position, like 1 o'clock or 2 o'clock?
That's a great point. So
Okay.
generally, when we have more like breast cancers that are malignant, they do tend to appear in the upper outer quadrant of the breast. So in this case, with it being on the left side, in the 1 o'clock position, that does make it in that upper outer quadrant. That doesn't necessarily mean that if it's in the like lower quadrants or if it's on the inner side of the breast that that's not cancer, but it just raises more suspicion for it being malignancy if it's in that outer quadrant. And then if we're on the other side, if it's the right breast, then the upper outer quadrant would be like the 10 or 11 o'clock position. So it just kind of depends on what side you're on. But great
Okay,
question.
thank you.
Yeah,
Thank you so much, and thank you for explaining it so well.
yeah, no problem. So now that we know a little bit more about her mass and her exam, what would we like to order to work up this mass to decide, is this benign? Is it cancerous? Is it, how are we going to treat it? Cole saying biopsy. I love that. Yes, absolutely. Is there anything that we would maybe want to do before a biopsy? Remember, she hasn't actually had any imaging done. So um, X-ray. Yeah, so an X-ray wouldn't be as good for like a soft tissue evaluation, but I love where you're going with it, that we would want to do some imaging first. So what we could do is either like a breast ultrasound or a mammogram, and that would be able to better visualize the soft tissue of the breast compared to an X-ray. But I think that, yeah, you're absolutely right that we would start with doing some imaging and then do a biopsy. So both of you are correct with your answers. So like I said, we're going to do mammogram. Depending on the results of the mammogram, we may also do a breast ultrasound. And then after we do this imaging, then we can do a core needle biopsy of the lesion. So this is her mammogram. It is a type of imaging that we do to evaluate breast masses and is also used for screening. So the interpretation of her mammogram was that she has an irregular spiculated hyperdense lesion with microcalcifications. And so these all are very like red flag words for cancer. If we see anything that's irregular, meaning the borders of it are like not well circumscribed or like well walled off, then that could indicate like a more abnormal tissue growth and potentially like an invasive process. Also, the microcalcifications are a red flag on imaging because sometimes when tumors grow so fast that the middle of the tumor or parts of it, the cells actually like can't get enough nutrients and oxygen to stay alive for how fast it's growing relative to its blood supply, that they actually die and have necrosis. And then after those cells die, they can just undergo calcification as part of the necrosis process. So generally, if you see microcalcifications in like a soft tissue, that can be in some cases associated with a cancer. So these findings can be then quantified into a classification called the BIRADS. And BIRADS is a guide for breast imaging that will correlate the findings with your likelihood for malignancy and what you're going to do to further work up the treatment. So with her BIRADS classification being a 5, as you can see on this chart, it's highly suggestive of malignancy, and we're for sure going to want to do a core needle biopsy to confirm if this is cancer or not. So so far not looking great, because these are like some red flags for cancer. But just so you guys know, like if it's a BIRAD 0 or 1 or even 2, the lower the score is, the less likely that it's cancer. So just to kind of run through the differential, I wanted to talk to you guys first about the different types of cancer that we would be concerned about. The first one is invasive ductal carcinoma. You may recognize this from being the diagnosis that her aunt had, the type of breast cancer that her aunt was suffered from when we learned about in her family history. This type of cancer usually only affects one side and is unifocal. Unifocal meaning within the one breast that there's only one mass or tumor affected. And this is the most common type of breast cancer. So this is 80% of all invasive breast cancers. In contrast with invasive lobular carcinoma, this one can actually present bilaterally or multifocally. So it can be either on both breasts or within one breast have multiple areas of tumor. It doesn't always have to be that way, but it's just a unique feature to invasive lobular carcinoma that you usually don't see with invasive ductal carcinoma. And then I also am going to talk about the anatomy, like the difference between what ducts and lobules are a little bit later. So if you're wondering like what the difference is there, we'll get to it. But invasive lobular carcinoma is also more rare. It's only 10% of all invasive breast cancers. So it's less likely that it's going to be this, especially because we only saw one lesion on her mammogram. Another type of breast cancer that is also rare is called inflammatory breast cancer. I do have a picture of it on the next slide to kind of show you guys what that would look like, but we see more like skin changes rather than like a solid tumor or a mass. And classically, it's going to have that sort of like orange peel appearance with like the skin dimpling. You can sometimes have like nipple discharge and redness and swelling of the breast with inflammatory breast cancer. And again, that's very rare. So we're probably not thinking this for our patient because she had a mass and didn't report any skin changes. And then, of course, we are hopeful that it's something benign, a benign breast mass, things like fibroadenoma or intraductal papilloma or a simple cyst could all be benign masses that can, present as tumors, but they're not cancerous. And so we don't have to be as aggressive with the treatment. So those are just a couple of different ones. Don't worry about the pathology of these or like how they're different from the cancers. I just wanted you guys to remember that there are still plenty of breast masses that are benign and not cancerous. This is the picture of the inflammatory breast cancer that I wanted to show you guys. So classically, we see this, I think, is it peau d'orange? I don't speak French, so I'm probably mispronouncing that, but it essentially is meaning like orange peel skin. So if you look at this like circle zooming in on the skin, it kind of has this like dimpling of the skin. And that's due to blocked lymphatic channels of the skin draining to the lymph nodes. So it makes those like pores and hair follicles look really large. We also can see like redness or rashes, inverted nipple or nipple discharge. So that's just what inflammatory breast cancer looks like. A lot of the times with the other two, the invasive ductal carcinoma and invasive lobular carcinoma, you really don't see any skin changes. It's just going to be the mass. So the results for her core needle biopsy, it did show a moderately differentiated invasive ductal carcinoma. And then further evaluation showed that it's estrogen receptor positive. And we'll kind of go through what that means, but essentially her tumor is responding to estrogen signaling for it to continue to grow. So as we'll learn a little bit later, breast tissue is highly receptive to different hormone signaling in order to decide like what it's going to be doing. And so certain breast cancers have hormone receptor status that can be used in the treatment of that cancer to help make it more specific for the tumor. So for our assessment and plan, we have a 54-year-old female with no significant past medical history, and she has a 2-month history of a left-sided breast mass, which is now 2 by 3 centimeters on exam. If you remember back to that picture, it also had the like the clock face position that I didn't include in this assessment, but definitely would be included in the physical exam findings. Her mammogram showed a BI-RADS classification of a 5 in the upper outer quadrant, and her core needle biopsy confirmed a diagnosis of ER-positive invasive ductal carcinoma. So our plan for this patient is to do staging with a CT scan for metastases. We don't take people to surgery to get it removed before we know that it has not spread anywhere, because if it's already spread to other organs, then removing your primary tumor site is really not going to be helpful in survival, because your cancer has already gone to other places. So depending on if her CT scan shows that she only has localized disease, then we can do surgical resection of the mass and a sentinel node biopsy, which is essentially looking for local invasion of her lymphatics, which can be still treated surgically depending on how advanced it is. And then we're also going to do adjuvant treatment with tamoxifen. Tamoxifen is a selective estrogen receptor modulator, or a SERM, and that is essentially going to block estrogen signaling to help the tumor not receive like the signal to keep growing. So plan for her will be CT first, and then surgery and tamoxifen. So right now that we've done our kind of case and assessment and plan, do you guys have any questions? And is this pace okay? Are we going like too fast or need to slow down at all?
Could you go back to the last slide for a second?
Yeah, absolutely. And yeah, so for your guys' notes too, if there's anything that we go through too quickly and you want to go back to, or when we're doing the quiz at the end, if there's any information that you remember seeing and you wanted to use to help you answer that question, then we can also always go back to those slides if you needed. I'll leave this up for just a couple of seconds and then we'll just keep going. Okay, I'm gonna just keep going on. We can come back to this later if you need to. Okay, so we're gonna first go through a little bit of breast anatomy and physiology. So obviously the primary role of breasts is to, feed infants when they're born, to produce milk, and to do breastfeeding. So breasts consist of milk glands, which are these lobules kind of at the end of the milk sacs, I guess, if you want to think of them that way. And then they're all connected to these ducts, which connect the lobules to the nipple so that the milk can, be released through the nipple and feed the baby. So we have the lobules, which are the actual sacs, the ducts, which connect the sacs to the nipple. And then we also have a lot of just like fat or adipose tissue in the breasts as well. That kind of depends on like your age and your reproductive status. If you've ever been pregnant or if you have children, then you tend to have more well-developed lobules and ducts compared to your amount of adipose tissue. So it just can vary a lot depending on where you're at in life. Your breasts also have a very extensive vascular supply and lymphatic drainage, because everything that's going to go into producing the milk, you want to make sure is adequately filtered and that you have enough blood supply to actually produce the milk. And then like I mentioned before, your breasts are highly sensitive to hormonal signaling. So things like progesterone and estrogen are the ones that are kind of throughout your entire like post-puberty life. And then you also have prolactin and oxytocin, which are hormones that signal during milk production and milk expression if you have a pregnancy or have recently had a child. So this is kind of, like I said, the difference between the lobules and the ducts. They're all lined by these epithelial cells, and that's the primary kind of cell type that's affected in these invasive cancers. And then you have these fibroblasts, and you can also have like lined with smooth muscle to help contract and move the milk along through those ducts. So a little bit more about breast cancer. So for some epidemiology, breast cancer is the most common cancer in women worldwide, with a rate of 1 in 8 women who will be diagnosed with breast cancer in their lifetime. And it does not just affect women, it does also affect men. 1 in 1,000 men will be diagnosed with breast cancer in their lifetime. The most common age for diagnosis of breast cancer, at least this is true in women. I'm not sure if this is the same in men, but it's 65 to 74. So you can kind of see on this chart here that it peaks up in this sort of late 60s, early 70s range. Sorry, I'm just trying to plug in my computer. I don't think my charger was plugged in well before. Okay, sorry about that. So the number one risk factor for breast cancer is age. Just statistically, as you age, you get more mutations accumulate that will cause the cell cycle to become dysregulated. And so age is the number one risk factor. Other risk factors are family history. So we don't know if this is true in this patient, but some mutations like the BRCA mutation can cause a significantly higher risk of breast cancer that can be inherited through families. A lot of the other mutations, however, are just sporadic that you get as you age and they're not inherited, but the BRCA mutation is inherited and is one of the cancer causing genes that runs in families. Obesity and excessive adipose tissue, because adipose tissue does convert estrogen or androgens to estrogen peripherally. So you can be in like a hyper estrogenic state from having excess adipose tissue, which can then again stimulate the breast to continue like growing and just modulating their turnover. So they can also increase your risk of breast cancer. Of course, just like almost everything, alcohol and tobacco use, smoking is bad for you. Smoking causes cancer, not just lung cancer, but lots of different kinds of cancer because it's a carcinogen. So alcohol, tobacco use can also increase your risk. And then your reproductive and hormonal history. So things like early periods or menarche is when you have your first period. So if you're really young when you first get your period, or if you have late menopause, if you have no pregnancies, or if you take estrogen replacement therapies, like for menopause symptoms, for example, then those can all also increase your risk of breast cancer. That's again, not to say that everybody who has these risk factors are going to get it, it just increases your risk. And then the pathology of breast cancer is really just like any cancer. You have this accumulation of mutations that will eventually lead to uncontrolled cell division and abnormal tissue growth. So next week, I'm going to do another virtual round. It's all about neoplasms or tumors and like how the actual pathologic process of these mutations causes uncontrolled cell growth and like what the different stages of that can be. And then lastly, just some symptoms of breast cancer. So the number one symptom is really just being asymptomatic, and they're detected on mammograms. That's why we do screening with mammograms, is because a lot of women who, they don't have any symptoms, they may not have a lump, they may not have skin changes or swollen lymph nodes. So we just like to try to catch it as early as possible by doing detection on mammogram. You can have a lump generally if it's painless, then that's more concerning than a painful lump. Painful is usually like a benign cause, especially if they're associated with your menstruation. So that can be a differentiating factor. Enlarged lymph nodes, especially in the armpit or axillary region, like we talked about before, is kind of the most common spot for lymphadenopathy in breast cancers. Nipple discharge, and then skin changes and skin dimpling. Again, I just want to emphasize that just if you have these symptoms does not mean that you have breast cancer. It just can be symptoms of breast cancer that, if you're worried, should be further worked up. This is going to be kind of featured a lot next week if you decide to come to the neoplasms and pathology virtual rounds, but this is just kind of showing the progression of like normal to what an invasive carcinoma is. So in normal, you have your like nice, smooth, uniform single cell layer of your epithelial cells and your basement membrane, and everything is just well contained and well structured. In hyperplasia, you're starting to get some mutations that cause a little bit of abnormal cell growth and can cause some thickening of this epithelial layer. But the cells all look pretty normal. If you look at them under a microscope, they all look the same and they all look healthy. If we see an atypical hyperplasia, then we start to see some of the cells looking not as normal or not as healthy. You can see some of the nuclei have a different morphology than their surrounding cells do. And you're starting to see a lot more thickness and overgrowth of those cells. For a ductal carcinoma in situ, this is essentially, it's a cancer at this point, but it hasn't yet invaded beyond this basement membrane. So it's contained to this outer layer and hasn't infiltrated the surrounding tissue yet. And then once it breaks that basement membrane layer, then it is defined as an invasive carcinoma, and you're at risk of having metastasis through your blood vessels and lymphatic channels. And as you can see here again, like some of these nuclei are super large. These cells are like all kind of irregular in their architecture and morphology compared to our nice uniform cell layer at the beginning. Any questions on the pathology before we wrap up our case? Okay, let's keep going. So for our evaluation and treatment, like I said, we're going to do staging with a CT scan of the chest, abdomen, and pelvis to see if there's any like end organ metastases. If the cancer has not spread anywhere and it's localized just to the breast, then you can do surgery and that can be curative. If the cancer has spread, like say you have metastases to your lung or to your bones or somewhere else, then you do not do surgery. You have to do systemic chemotherapy or radiation because your cancer has already spread and seeded in those areas. So taking it out just in the breast isn't going to remove the cancer from the body. For surgical options, if you have a local cancer, a mastectomy, which is the total removal of a breast, may be done. It can be either on one side or you can do both sides if you're worried about potentially having a high risk in the other side. Even if there's no tumor and it's unaffected, you can still do a bilateral mastectomy. And some patients opt for breast reconstruction with implants, and others choose to just have their breasts removed and not do reconstruction. It's really just patient preference. However, some patients would like to do a breast sparing surgery, and in this case, they can undergo a lumpectomy, which is just taking out the actual tumor with like wide margins on it to ensure that you have all of the abnormal cells. And then you can follow that with radiation. And in these patients, the lumpectomy and radiation has the same survival as a mastectomy. So you don't have to do a mastectomy in order to have a curative surgery. You can also do the lumpectomy and radiation. Both of these surgeries, you're going to do a sentinel lymph node biopsy to look for localized invasion of your lymphatics. So that's essentially, I have a really cool video on the next slide that I can show you guys how they find where the sentinel lymph node is. But that's just sort of like an insurance to make sure that it truly has only stayed in the breast and it's not at risk of spreading to other places. So we're gonna do this video really quick. Let me know if you have trouble. I don't think there's really any like audio that's important here, but I'm gonna make sure that you guys can hear that.
To find the sentinel lymph node. In the blue dye technique, a small amount of blue dye is injected into the breast near the tumor. The dye spreads rapidly through the region. After 5 to 10 minutes, it will have traveled to the lymphatic vessels in the area. A blue stained vessel is found and followed until the lymph nodes are reached. The blue stained nodes closest to the tumor are the sentinel nodes. The sentinel nodes are then removed and examined for the presence of cancerous cells. In the radioactive colloid technique, a small amount of radioactive material is injected into the breast 4 to 6 hours before surgery. After sufficient time has elapsed, a surgeon uses a special handheld detector to identify the areas emitting high levels of radiation. These areas contain lymph nodes that have taken up larger amounts of the radioactive material. These nodes with high levels of radiation are called hot nodes. And sometimes that is done the day before or the day of surgery.
So I think that's really cool. Like one of the awesome parts of surgery is that they have like the most amazing technology to really trace exactly where these lymph nodes are and make sure that you're not taking just like a chunk of nodes out that have, you know, important purposes and risking complications to the patient and their surrounding anatomy. And it's almost like I could just, with this radioactive dye, they have a probe that kind of looks like, I don't even know what to get, like just like a pen that detects the radioactive material, and you kind of hover it over the area that you would expect the node to be. And it's like a metal detector where the sensor for it, it'll actually like beep louder and louder and louder, and, you know, kind of just like have like a constant beep if you're sitting on that hot node. And usually after you take out the node, you can confirm that it is actually the correct node. I'm trying to see if they have it on here or not, but yeah, you can actually confirm once the node is taken out. If you just set the pen down on it, then it'll like light up and you can see exactly how much radioactivity there is. So it's really cool to how they can use the technology in surgery this way. And then a little bit about pharmacology and adjuvant treatments. So I talked a little bit before about the hormone receptor status. This is something that we want to test all breast cancers for because it can be used to guide further treatment options. So like we know that our cancer or our patient's cancer is estrogen receptor positive. So she's going to be treated with tamoxifen, which is a selective estrogen receptor modulator. And as you can see, like in this diagram here, a normal breast cell has, you know, some receptors for the hormones, but in the cancer cell, you have this overexpression of receptors. And so if you take a antagonist or something that will bind the receptors but will block the actual estrogen that would stimulate the cell to continue growing and dividing, then you can reduce its growth and also prevent recurrence with that. Another common mutation that we would screen for is HER2, which stands for human epidermal growth factor receptor. And this is pretty much the same concept of having these growth factor receptors overexpressed on the surface, but instead of a hormone estrogen, it's going to be this human epidermal growth factor. And so we can give a drug called trastuzumab, which is an antibody that it's going to basically do that same thing. It's going to block the receptor so that the growth factor doesn't cause like continued tissue growth. So kind of cool how you can target the tumor specifically with the proteins that are causing it to grow. Some cancers are not positive for any of these. They're called triple negative breast cancer. I didn't actually list that you can have progesterone positive tumors on here as well, in addition to estrogen. But so if you have estrogen negative, progesterone negative, and HER2 negative, and that means you are triple negative breast cancer, where none of these hormonal modulators or the trastuzumab antibody is going to show a response in the tumor. So these cancers are generally more aggressive and have a higher rate of recurrence and require more traditional chemotherapy rather than these kind of cool targeted therapies. So that's why we want to make sure we check all of these cancers for if they have certain molecular markers, because they can help decide what treatments to do. It can also be prognostic and help us understand the rate of recurrence, and depending also on the genetic status of them. So if these tumors are positive for that BRCA gene that we talked about before, that is a gene that can be inherited and passed on into other family members. So it may also be beneficial for patients to know if they're positive for a mutation that can potentially affect their family members. And that could potentially influence when the family members get screened for cancer. It could be sooner than what the normal guidelines are because they're higher risk. So for our patient wrap up, she did end up electing to undergo bilateral mastectomy with a sentinel node biopsy that came back negative for metastasis to her nodes, and then also opted for breast reconstruction. So she went through that surgery and had no complications. She is being treated with an adjuvant tamoxifen therapy to reduce her risk of recurrence, and is enjoying working in her garden at home again. So That's good. I like to write happy endings for my patients. And then lastly, just a little bit about surgery. So I like to add these little about the specialty things at the end. And probably like if you've ever met a surgeon, you know that they do the coolest things. So surgeons help diagnose and treat operative conditions and can work in literally so many areas of the hospital. They can do emergency and acute care type surgeries, which would be things like traumas, car accidents, falls, things like that. And then acute care surgeries like appendicitis, cholecystitis, bowel obstructions, a lot of abdominal stuff is what general surgeons do. You can also have in an outpatient or elective setting, so patients who need bariatric surgery for weight loss, skin procedures like big melanoma resections or lipomas. And then, of course, you know, treating cancers as well, where you can take out people's tumors and essentially cure them of cancer. A lot of surgeons also have clinic where they follow up with their patients after they get surgery and make sure that they're still doing well. If you're like a surgical oncologist, for example, in this case, then you might co-manage a patient's oncology care with a medical oncologist who will be doing a lot of their like chemotherapy or pharmacologic therapy, and then you can be following for their surgical progress. Surgeons can also work in the ICU and take care of really critically ill people. They can do consults down in the emergency room. So they literally do like everything. And like I said, they use really amazing technology. They get to work with their hands and see really like real tangible results on their patients and have that instant gratification of having like literally fixed them of their problem. So for how to become a surgeon, all of these paths start with a general surgery residency, which is 5 years and usually has an optional 1 to 2 years of research, which is recommended in fellowships that are really competitive. The two most competitive fellowships that I have listed here are pediatric surgery and surgical oncology. So then those ones you would be recommended to do research in your residency and then go on to do that additional fellowship. Other fellowships, though, can be 1 to 2 years and are not as competitive, so you wouldn't have to do that research necessarily. But you have all these different fields that you can subspecialize in or just stick with general surgery and be like a true generalist. And in certain practice settings, like especially in rural or community hospitals, you can practice like seriously the full scope of surgery, and it's really, really cool. I'm hyping up surgery a lot because I thought I was going to be a surgeon. I was planning on applying to general surgery, and then I found anesthesiology, which is also very cool, and you get to be in the OR, but they let you sit down. So that's not the only reason, but anesthesia is also very cool, and we work closely with surgeons, and they're really amazing people, and they have such a great work ethic and do some really amazing things for patients. These are my sources. And so now it is time for you guys, if you'd like to work on that quiz, I can always go back to the previous slides if you guys have any questions or things that you want to revisit to help with the quiz questions at all. I'm also happy to chat about anything related to medical school, or I think AMCAS either opened like yesterday or today. So if anybody's applying this year, I wish you all the best in your application cycle, and am always here for any questions that you guys might have. So thank you again so much for coming. I appreciate your patience. I feel so bad for being late, but I was just like having some personal stuff going on and like totally lost track of time. So I appreciate you guys being here, and yeah, thank you again, and let me know if you have any questions.
I have a quick question.
Yes, please go.
Will a mammogram or the breast ultrasound be the true diagnostic for breast cancer?
No, so that would be kind of to help us evaluate if we would want to do a biopsy. Really, the only way that we can do a true diagnosis of breast cancer is by taking a sample of the tissue and looking at it under a microscope and actually seeing the morphology of the cells and seeing if that's actually a cancerous tumor. So While it's a great screening tool, and if we see something abnormal on a mammogram that might warrant looking at it closer with an ultrasound, the only way to make a definitive diagnosis is by doing a biopsy. That's a great question.
Okay, that makes a lot of sense. Thank you.
Yep, no problem. Yeah, a lot of the times we can see people who have maybe like a potentially abnormal or suspicious looking finding on their mammogram who they just, want to be rather safe rather than sorry. So they can go and do a biopsy and it might actually be totally fine. We like to generally work up things that are suspicious or that we're not sure about rather than leaving it to chance and calling it benign when it could actually be cancer. Similarly, sometimes things move really quickly. And even though we recommend people get mammograms every 1 to 2 years, some of these cancers can be really fast growing and aggressive. And so they, might have looked normal on mammogram a few months ago, but if they're really, really showing signs of a potential cancer, then we might jump right to doing an ultrasound and then doing a biopsy right away instead of waiting for them to do a mammogram. So good question. What else can I help you guys with? Just curious, is anybody applying for med school this year? Send in your applications.
I sent in my application last night.
Oh, congrats. That's so exciting. That's like already in itself, like just to even get it in is a huge accomplishment. So you should definitely celebrate. And I'm sending you all the good vibes for secondaries and interviews and the rest of the season.
Thank you. I'm taking the MCAT on Saturday, so that's definitely a big indicator.
Yes. No, I think it's smart that I know a lot of people who like submit so that you can kind of have that verification process going and then take the MCAT while you're waiting to get that verification. So I think that was a smart move for sure.